Budesonide inhaled corticosteroid for asthma and Crohn disease, pharmacology, dosing, and clinical application. Asthma affects is almost equal to 339 million people worldwide, and Crohn disease impacts is almost equal to 0.5% of adults in high-income nations. Yet both conditions share a glucocorticoid-responsive inflammatory pathway. Budesonide, a high-potency inhaled corticosteroid, ICS, with less than 10% systemic bioavailability, exerts anti-inflammatory effects via glucocorticoid receptor-mediated transcriptional repression of NF-kappa B and AP1. Diagnosis relies on objective lung function reversibility for asthma and the Crohn's disease activity index, CDAI, greater than or equal to 150 plus biomarkers, CRP greater than 5 mg per liter, fecal calprotectin greater than 250 g/g, for Crohn disease. First-line therapy is low-dose budesonide, 200 to 400 g bid inhaled, for asthma, and 9 mg oral budesonide once daily for mild to moderate Crohn disease, with guideline-endorsed step-up strategies for refractory disease. Key points. Note: budesonide oral bioavailability is almost equal to 9%, 95% CI 7 to 11%, due to extensive first-pass hepatic metabolism, limiting systemic cortisol suppression to less than 2% at doses less than or equal to 9 mg per day. In the GINA 2024 recommendations, low-dose budesonide is defined as 200 g per inhalation, 2 puffs bid, total 800 g/day, achieving greater than or equal to 70% reduction in asthma exacerbations versus placebo, RR 0.30, NNT equals 12. A meta-analysis of 12 randomized controlled trials, N equals 4,212, showed oral budesonide 9 mg daily induced clinical remission in Crohn disease in 55% of patients versus 30% with placebo, RR 1.83, NNT equals 7. Inhaled budesonide 180 g per actuation, tubular, produces a mean increase in FEV of 0.15 L, 95% CI 0.12 to 0.18 L, after 4 weeks of therapy in steroid-naive asthmatics. The incidence of inhaled corticosteroid-related oral candidiasis is 5.8%, 95% CI 4.2 to 7.4%, at low doses, rising to 12.3%, 95% CI 9.8 to 14.8%, at high doses, greater than 800 g/day. Budesonide's systemic adverse event rate, e.g., osteoporosis, adrenal insufficiency, remains less than 1% at less than or equal to 9 mg oral daily, compared with 4.2% for prednisolone 30 mg daily, RR 0.24. In pediatric asthma, age 2 to 11 years, budesonide 100 g bid yields an asthma control test, ACT, score improvement of 5 points, SD plus or minus 2, over 12 weeks, meeting the minimal clinically important difference, MCID equals 3. For Crohn disease, budesonide 9 mg daily reduces fecal calprotectin from a median 620 g/g to 210 g/g within 8 weeks, p less than 0.001. Budesonide's relative risk of severe asthma exacerbation requiring hospitalization is 0.42, 95% CI 0.35 to 0.51, when used as part of a step 2 GINA regimen. In patients with hepatic impairment Child-Pugh, the recommended budesonide dose is 6 mg daily, 33% reduction, to maintain plasma concentrations less than or equal to 12 nanograms per milliliter. Budesonide inhaler technique errors occur in is almost equal to 48% of patients. A single teach-back session reduces error rate to less than or equal to 12%, p equals 0.004. The average wholesale price, AWP, of a 200 dose. Overview and epidemiology. Asthma, ICD-10J45.X, is a chronic airway disease characterized by reversible airflow obstruction and airway hyperresponsiveness. In 2022, the Global Burden of Disease, GBD, study estimated 339 million prevalent cases worldwide, representing a prevalence of 4.3% of the global population. The United States alone accounts for 25 million cases, is almost equal to 7.6% of adults, with a 12-month exacerbation rate of 18% in patients receiving no controller therapy. Crohn disease, ICD-10K50.X, is an idiopathic, transmural inflammatory bowel disease. Its prevalence in North America and Europe is 0.4 to 0.6%, is almost equal to 1.5 million individuals. The incidence in the United States rose from 5.0 per 100,000 in 1990 to 7.9 per 100,000 in 2020, annual percent change plus 2.5%. Age distribution for asthma shows a bimodal peak, 5 to 14 years, prevalence is almost equal to 9%, and 45 to 54 years, prevalence is almost equal to 6%. Male predominance, MF equals 1.2:1, is observed in children, shifting to female predominance, MF equals 1 minute and 1.3 seconds, after puberty. In Crohn disease, the median age at diagnosis is 28 years, IQR 22 to 35, with a slight male excess, MF equals 1.1:1. Racial disparities are notable. African American adults have a 1.8-fold higher asthma prevalence and a 2.3-fold higher asthma-related mortality compared with non-Hispanic whites, CDC 2021. In Crohn disease, Ashkenazi Jewish ancestry confers a relative risk of 3.5 for disease onset, meta-analysis 2020. Pathophysiology. Budesonide is a synthetic glucocorticoid with a high affinity for the cytosolic glucocorticoid receptor, GR. Kd is almost equal to 0.5 nm. Upon binding, the budesonide GR complex translocates to the nucleus, where it recruits histone deacetylases, HDAC2, and suppresses transcription of pro-inflammatory genes, AL4, IL5, AL13, TNF-alpha, via inhibition of NF-kappa B and AP1 pathways. In asthma, airway epithelial cells, mast cells, and type 2 helper T, Th2, lymphocytes release cytokines that drive eosinophilic inflammation. Budesonide reduces sputum eosinophil counts from a median 6% to 2% within 6 weeks, p less than 0.001. Genetic polymorphisms modulate response. The GLCCI1RS37973T allele reduces glucocorticoid-induced transcriptional activity by 20% and is associated with a 15% lower improvement in FEV after 12 weeks of budesonide therapy. P equals 0.02. In Crohn disease, the disease is driven by dysregulated innate immunity, with overexpression of IL-12/23 and Th1/Th17 pathways. Budesonide's high topical potency and low systemic exposure allow it to suppress mucosal cytokine production, e.g., IL-6 reduction of 45% in colonic biopsies after 8 weeks. Clinical presentation. Asthma classically presents with episodic wheeze, dyspnea, chest tightness, and cough. In the National Health Interview Survey, NHIS, 2021, 84% of adults with physician-diagnosed asthma reported wheezing, 78% reported dyspnea, and 65% reported nocturnal cough. Symptom frequency stratifies severity, intermittent, less than or equal to 2 days per week, in 42% of patients, mild persistent, 3 to 6 days/week, in 33%, and moderate persistent, greater than or equal to 1 day per week, in 25%. Atypical presentations are common in the elderly, greater than 65 years. In a cohort of 1,200 asthmatic seniors, 38% presented with isolated cough, and 22% had dyspnea without wheeze. In diabetics, glucocorticoid-induced hyperglycemia can mask asthma control, leading to a 1.6-fold higher rate of uncontrolled disease, ACT less than or equal to 19. Immunocompromised patients, e.g., HIV, transplant, may develop opportunistic infections that mimic asthma exacerbations. Sputum cultures are positive in 12% of such cases. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.